This is the COVID-19 and Emerging Infectious Disease track. This split session includes Vaccinating with Confidence, Strategies for Improving Vaccination Against COVID-19, presented by Jessica Butts, and COVID-19 Vaccine Efforts in Indian Country, Clinical Updates, presented by Holly Van Loo. Jessica Butts is a health scientist in the malaria branch at the Centers for Disease Control and Prevention, supporting the President's Malaria Initiative. She is currently deployed with the, hold on just a second, let me let somebody else in, sorry. She is currently deployed with the Tribal Support Section in the State, Tribal, Local, and Territorial Support Task Force within the CDC's COVID-19 response. Her responsibilities focus on providing education and information about vaccines and strategies for increasing vaccine confidence in tribal populations, preparing and developing vaccine-specific materials, and responding to vaccine-related questions from TSS deployers, Indian Health Service, and tribal community leaders. Captain Van Loo is a clinical pharmacist at Phoenix Indian Medical Center within the Indian Health Service. She is the immunization coordinator at her medical center, where 45,000 vaccines are administered yearly. She manages all procurement, storage, and distribution of vaccines. She is a trainer for the pharmacist and pharmacy technician immunization certificate programs for the Arizona Pharmacy Association. Captain Van Loo works at the local and national level to educate pharmacists, providers, and nurses regarding immunizations. She is currently the IHF COVID Vaccine Task Force Deputy Lead, standing up an agency vaccine program to distribute, track, and administer COVID-19 vaccine. Holly lives in Phoenix with her husband and 2 young daughters. So welcome, both of you. I believe we are going to start with Jessica. So Jessica, I don't think I have anything else. Just take it away.
Actually, we're going to start with Captain Van Loo.
Oh, I'm sorry.
We might have switched it up on you. No problem. No problem.
All right. Good morning, everyone. Thanks so much, and appreciate that introduction. I hope you're having a good morning. I'm going to give a brief overview of Indian Health Service, how we've attacked the concept of the COVID-19 pandemic in regards to vaccines, and give a brief overview in general of some of our best practices and successes. Just an overview real quick of Indian Health Service. Indian Health Service serves 2.6 million American Indian Alaska Natives. Our user population is about 1.6 million, and those are individuals who have had at least one ambulatory care visit in the last 3 years. We serve 574 federally recognized tribes across many of the states in the United States, and we have over about 15,000 healthcare employees. We also have a variety of different ways that Indian Health Services are operated, whether they're IHS operated, tribal health programs, or urban Indian organizations. And we have either hospitals, ambulatory care clinics, or referral centers, or combinations of both, or of all three, actually. COVID-19 in Indian country has been significant. We have been disproportionately affected by the SARS-CoV-2 virus, and having rates of infection much higher than the general population, up to 3.5 times higher than the general population, elevated rates of hospitalization, and definitely higher rates of mortality at younger ages. So you can see here that over 10 times higher the mortality rate for American Indian Alaska Natives that are 20 to 29, 11 times higher in that 30 to 39 group, and 8 times higher in the 40 to 49 group. So we've seen loss. And in fact, just this week, we had an employee pass from my facility. We've now lost 5 individuals only at my hospital. So we are continuing and remaining committed to using layered approaches for ensuring that our people remain safe, both in our hospitals and in our communities. Items such as social distancing, mandatory masking, hand hygiene are really critical pieces. And I even saw an article yesterday talking about how some tribal lands are requiring masks and have mask requirements in place, even if it's something that's been mandated that's not possible in that state. So tribal leaders are being very adamant to make sure that we're using these layered approaches. What's really important is that we wanted to make sure that if and when we did receive vaccine, that we wanted to make sure it was equitable, and we wanted to make sure that tribes and tribal leaders were heard, and to make sure that we could distribute that vaccine to ensure that we could reduce COVID impact in our communities. We were offered the opportunity by the CDC to be recognized as what they call a jurisdiction. So that would be similar to like a state immunization program. This was really critical because this grew out of the need for this government to government sovereign nation example, where tribes really wanted to be able to own and manage some of the components of vaccine, such as determining what their prioritization schedule may be in the very early phases of vaccine distribution. We had a number of things already working for us. One was that we had scalable medical logistics with our National Service Supply Center. It's a center that is often able to provide PPE and other different components, including medications, monoclonal antibodies, and we have an existing distribution network in place. We also have an established healthcare record, an electronic healthcare record that we utilize across the agency that's very robust in our ability to be able to identify patients that might be at risk or who may need certain vaccinations. So that was a really great benefit to get started with. So we had requested a special allocation. We've had the pandemic of 2009, and there were some issues with certain tribes being recognized by the state jurisdiction and having adequate and equitable distribution of vaccine during that time. So this really grew out of that moment. We wanted to make sure that we had done tribal consultation, urban consultation, and wanted to make sure we were hearing tribes and tribal leaders about their needs and what they thought this program should look like. And we wanted to also capitalize on the opportunity that we've already have really great existing relationships in place with the state jurisdictions, the state immunization programs. American Indian Alaska Natives are eligible for the Vaccine for Children program, and that's really critical in that we have, for all of our children 0 to 18, we're able to receive vaccine from the CDC to make sure that we can use it in American Indian Alaska Native populations. We already had those existing relationships with the state jurisdictions because they're the ones who help to distribute and manage the VFC program. So we already had a lot of many critical steps in place and many relationships that were already in existence to allow the jurisdiction to be created successfully. Additional items that are important regarding Indian Health Service is that we are a healthcare delivery system. We know our patients, we know our tribal communities, we have individuals who are unique in their job functions, and we know that we have outreach into our communities. That includes folks like public health nurses, community health representatives, and individuals who are constantly in our communities communicating with our folks and being able to put out critical messages. We also know that our electronic health record is incredibly useful to be able to identify our priority populations that were dictated by the ACIP in December, January, February. So we were able to very easily identify those people who were at risk. So those who may have an underlying medical condition, individuals based on age. So we were able to very simply run some lists, contact patients. We have lots of mechanisms in place to be able to do outreach, such as robocalls, sending letters, text messaging, all different kinds of opportunities across the agency. We have a baseline of really incredible immunization rates, both for pediatrics and for adults. So we pride ourselves on our ability to address vaccines at every visit, making vaccines at every encounter a priority. We have some unique relationships with the Bureau of Indian Education, where we have a number of different tribally operated, BIE operated, and Navajo schools So we have access to a great number of adolescents that are American and Alaska Native, as well as some tribal colleges, 37 tribal colleges where we've been able to host vaccine events at the facility, work with leadership to make sure that we're offering vaccination to staff and faculty as well. And then most critical is that we have tribal governments and partners that are able to reinforce the message about vaccine. We have some really amazing best practices, Albuquerque, Navajo, and even Alaska. And Alaska chose not to go with the Indian Health Service for their vaccine distribution, but they have been just a stellar example of definitely a wonderful rollout for vaccine. What did our vaccine task force look like? Well, we recognized that we needed to stand up a program in order to be able to distribute vaccine. So we created the vaccine task force. It really is a group of 6 critical teams that are interdisciplinary with expertise at all levels to make sure that we are addressing all the needs for vaccinations and this whole concept of prioritization, distribution, administration of vaccine. So what were our key pre-planning activities? Well, we hosted a tribal consultation and urban confer to make sure that we were able to hear the voices of the tribes and tribal leaders. We heard what they said, and they really wanted to be able to identify their own priority populations. They wanted to be able to administer vaccine to not just beneficiaries or those people who are members of federally recognized tribes at their medical facility, but they wanted to be able to vaccinate people who live and work in their communities, because that's where really we make the biggest difference. So that was a key component. And then we also wanted to make sure that we could spread messages quickly from not just the headquarters level, but also all the way down to the local level. So we have the national level, the area or regional level, and then we have our site vaccine points of contact that we want to make sure that we get messages out to that field level folks. We've had ongoing communications with tribes, tribal organizations, and what the White House has been really instrumental in making sure that we're addressing the needs of the tribes. We developed a plan, the IHS COVID-19 vaccine plan, where we outlined our strategies, and we were able to coordinate with the CDC, the Federal Vaccine Response Operation, and other folks to make sure that we were thinking through all of the components about creating a jurisdiction and how to distribute vaccine. We ended up having 355 Indian or IHS Direct, sorry, kid text there, IHS Direct, tribal and urban Indian organization sites that chose the Indian Health Service. And as mentioned before, sites in Alaska did choose to go with the state, and we've had a large number of sites that chose to go with the state for their jurisdiction. They may have had wonderful and existing relationships with their those individuals, so they went ahead and decided to go with the state for distribution. Here are some photos of the early rollout of vaccine. We really went all out. This picture here at the top with the helicopter, we partnered with the Coast Guard to deliver ultra cold vaccine to different states within the Bemidji area. We also worked to make sure that we address the needs of the healthcare providers, our elders, and other populations. It was a unique experience. We are continuing to learn, but it was definitely unique when we had to open like the ultra cold shipper box and determine what do we need to do here, how do we need to handle this, all sorts of learning curves there. So population estimates were critical to tribes and tribal leaders. They, as mentioned before, they want to make sure that they could not just vaccinate individuals that were beneficiaries, but those who are in our communities. And so they did not want to be limited by the user population. That's those folks who had one visit in the last 3 years. And so we said, you know what, it's okay, give us your number, tell us how many individuals you plan to vaccinate in your facility. And so that number that they provided was an estimate that may have included healthcare providers, volunteers, students, beneficiaries, non-beneficiaries, or any other individual that they wanted to make sure that they were vaccinating. And that total number came out to 2.1 million individuals. Now we know this is slightly elevated compared to our typical user population, or those folks that are American Indian Alaska Native that we serve for their health care on a routine basis. That estimate is probably in more of the range of 1.2 million, but we recognize that discrepancy and that difference, but we wanted to be able to offer vaccine to anyone that tribes and tribal leaders wanted to vaccinate. Here is a comparison of the U.S. Trends at the top. You can see this is the number of doses administered over time, beginning from mid-December, peaking in approximately mid-March and early April, and then continues to decline. We're seeing this current uptick as well as people begin to, some of our movable middle folks are beginning to accept vaccination. At the bottom here is the IHS graph. It looks somewhat similar, but definitely shifted to the left. And what we believe is we peaked a little bit earlier than others. We were getting vaccine out to our areas, getting vaccines out to our sites, and we were doing a lot of high-level work, a lot of peak numbers as early as February. We also were offered an opportunity to have a bonus allocation. We were able to receive 130,000 additional doses to our jurisdiction to meet the needs of the American Indian Alaska Native population. So that really made a difference. We could see that second week in February and second week in March, we capitalized on the opportunity to have that additional vaccine, and we were able to administer it. We had quite the challenge at the time trying to get through that 130,000 doses. So we just want to celebrate the amazing opportunity that we've had to receive and distribute vaccines to the American Indian Alaska Native population. We have administered over 1.55 million, is that 1.57 million at this time. And we have actively worked to make sure that we're seeking out our American Indian Alaska Native folks to make sure that we're addressing their needs for not just adolescents who now have that expanded exposure. We have vaccinated probably about 37% of individuals 12 to 15 years old have at least one dose, and about 27% have been fully vaccinated. We've administered over 500,000 doses to our American Indian Alaska Native adults, and about over 400,000 are fully vaccinated. And some of our areas have just done amazing work. They have very large numbers of very large user pops. And so, for example, Oklahoma City has given over 390,000 doses, which is just stellar. The workload and the amount of work that they put in is just phenomenal. As mentioned before, for the IHS jurisdiction, not all sites decide to go with the IHS. We are currently distributing about 63% of all doses that are administered across the Indian Health Service. Here's an example of our demographics, those folks that we've administered vaccines to. A bit largest proportion, as you would expect, are American Indian Alaska Native. We do have a large proportion of individuals who have listed as an unknown race or ethnicity. So it's hard to know if a portion of them are another race. We just simply don't have the information. The CDC does recognize that American Indian Alaska Native rates are higher than other race and ethnicities, topping out here right now at least one dose is 52% and fully vaccinated 44.1%. This is a more cumulative view of both the state jurisdiction and the Indian Health Service jurisdiction in total. So it's been amazing to see this great work across the country. And in fact, we've had some really great press recently, well, throughout the entire pandemic and vaccine launch. We've had a lot of really great articles written about the successful program. So here's just a snippet from the Los Angeles Times that was recently published. We have a New York Times article that's being published, I think this week. And like Dr. Christensen says here at the bottom, it's been a tremendous effort all across Indian country. Some additional photos here working with the ultra cold freezer. In the bottom right, you can't see her face, but this is my pharmacy technician, Vanessa. Vanessa is a certified pharmacy technician who was really eager to give vaccines, and with the PrEP Act expansion, she has actually administered more vaccines than any pharmacist, nurse, or other qualified provider on campus at my medical facility, where we've given over 30,000 doses. So, you know, allowing people to work to the highest level of their licensure has been really critical to the Indian Health Service to use all available resources. The collaborations were just the key component. We have just amazing opportunities to work with our tribes, to work with our urban Indian organizations that were referral locations, to create partnerships to be able to offer vaccines to our urban Indians, and to also be able to amplify our vaccine efforts. We've had critical support from our CDC partners, many of which are on this call today. Thank you, guys. Also, our federal vaccine response operation, we've had a liaison, an Indian Health Service liaison present at Operation Warp Speed and what is now called the Countermeasures Acceleration Group. We've had someone there and present at all times to make sure that our voice is being heard. We've also wanted to make sure that we're capitalizing on key opportunities to discuss opportunities with our federal partners, including FEMA and the National Guard. We've had many successful events where we've been able to utilize their expertise. And then, of course, our state and our local partners have been instrumental to our successes. Well, what have been our challenges? Oh boy, have we had some challenges. I think everyone has with the rollout of the vaccine in general, but we've had some unique cultural challenges, some concerns with vaccine acceptance. We've worked diligently with the CDC. The tribes and tribal leaders have been working to really create amazing messages about caring for ourselves, caring for our elders, and caring for our community. We also utilize a really useful method called the hub and spoke model, where we received a vaccine in one location, but we're able to redistribute that vaccine to small and remote rural populations. We do have a lot of variation with federal, tribal, and urban sites. They often say if you've been to one IHS site, you've been to one IHS site. There are so many variations between tribally run, urban Indian organizations, and federal facilities. So we have a lot of, it is a little bit difficult sometimes when we're sending out messaging, trying to meet the needs of everyone. Sometimes our data sharing is quite complex. We're being recognized as a jurisdiction. We report a certain way, but that doesn't always get reported the same way. The vaccines would typically be reported to the state agencies and the state jurisdictions. So it gets a little confusing when we're looking at the data and we're constantly having to describe how our jurisdiction works and how the data is a little bit different, that we only have a small piece of the story because we are only giving that 63% of the administered doses within the Indian Health Service. Then we also have folks who may live far from their registered Indian Health Service facility. We know that we had a lot of people come back to the reservations to be vaccinated when we had access to vaccine. So we've seen a lot of change in movement with trying to meet the needs of everyone who wanted to be vaccinated. And then we also use those private partnerships at our urban Indian referral sites, including the University of Maryland was helpful at the site in DC for the Baltimore Native American Lifelines Urban Indian Referral Center. What were our keys to success? Just those strong partnerships. They were critical, and the tribal leaders constantly messaging. For example, President Nez in the Navajo area is just always providing messaging, reinforcing vaccination, encouraging people to take this seriously to make sure that we can protect the American Indian Alaska Native people. We also focused on equitable distribution and redistribution. That was a key factor. We made sure everything was equitable. It was based on percentages and populations. We wanted to make sure there was no concern regarding who was getting what amount of vaccine when we were in limited supply. We were very effective at calling out, calling in, and getting their priority populations vaccinated. And we definitely have had this great sense of community and preservation of culture. This is the one critical factor that I think has been so important to our success across Indian Health Services. It's just that preservation of culture, calling upon our elders to encourage our young folks, calling upon our young folks to encourage our elders, trying to preserve culture, tradition, and language of the elders as well. We also built new relationships. We had existing relationships with our National Service Supply Center and distribution networks, but we created new processes. We built upon what we already had going on, and we were the first folks. We had already done very well with our distribution. We were the first jurisdiction to move from, instead of pushing vaccine out to the site, we began to offer people the opportunity to order what they need, how much they needed, and which brand they wanted at the time when they wanted it. We also were early to adopt vaccines in routine care. So every time someone was seen by the physician, they come into the emergency room, they come into the women's clinic, we're addressing vaccines at every visit, attempting to offer vaccines at every encounter, including COVID-19. I encourage you to take a look at our IHF Vaccine Resources. We do have a web page where we have a number of different technical resources, also some frequently asked questions, some promotional materials that may be useful and customizable, a lot of other components too, webinars and promotional materials that we have on board. Down here at the bottom, this is Kaylee, Commander Kaylee Fretlin. She's my also my partner in crime, my deputy co-lead for the Vaccine Task Force. She's on leave this week, but it's just really been an effort from all levels, and we just really appreciate how this vaccine has offered us hope. And I think that's it. Now we'll transition over to Jessica Butts with the CDC. It looks like she's taking a moment trying to get her screen set up here.
Yeah, I was just going to see, I don't know if there were any questions for Captain Van Loo before I jump in. Okay, well, I will go ahead and get started then. I did notice my bandwidth wavering slightly during Captain Van Loo's presentation, so I'm going to go off video during presentation mode. But just want to confirm you guys can see the presentation. Okay, great. Well, thanks, Captain Van Loo. It's so fascinating to learn about all of the complexities and the planning and the considerations that have gone into and continue for ensuring vaccine access for tribal populations, and particularly those successes that you highlighted. So appreciative of your presentation. Again, my name is Jessica Butts. I'm a health scientist with the Centers for Disease Control and Prevention, currently serving in the vaccine unit of the tribal support section within the CDC COVID-19 response. So I'm really grateful to have been invited here today to talk with you about strategies for improving COVID-19 vaccination uptake and increasing vaccine confidence. Let's see, trying to advance. Okay, there we go. So the COVID-19 vaccine communications activities and the outreach efforts that we undertake have vaccine confidence at their core. We define vaccine confidence as the trust that individuals and communities have in the recommended vaccines themselves, the providers who administer those vaccines, and the processes and the policies that lead to vaccine development, to licensure, manufacturing, and recommendations for use. So this foundation of trust is really critical in achieving vaccine uptake amongst various populations and communities. We tend to think about vaccine confidence on a spectrum. It's helpful to understand that this is a dynamic process, and it's often expressed in people's behaviors. So on one end, there are people who refuse vaccines and may never change their mind. On the other side of the spectrum are those people who were first to get in line for the vaccine. And then, of course, we have those people in the middle. So I know Captain Van Loo made this reference earlier. This is a group that we refer to as the movable middle. So the movable middle is generally made up of those who are still waiting to see what happens. And it's really who we're trying to reach with our vaccine communications and our outreach. And depending on your area of the country or your community, this section may still be quite large, but for much of the US, what we're seeing is that this area has been shrinking. So as the vaccines have been in circulation longer, we see that some of those who were waiting to see have taken steps now to get vaccinated. So for the movable middle that remains, we need to tailor and target our vaccine confidence messages to address the specific barriers that are relevant for those groups. It's also important to recognize that confidence in vaccines can change. Emergence of new studies or data can shape messaging. And this messaging in turn can shape the social norms that develop in communities. So for example, an individual may be on the refusal end of the spectrum, but if they begin to receive the message that millions of people have been vaccinated safely, they may move from refusal into passive acceptance or even demand for a vaccine. Unfortunately, events can also move people backwards in the spectrum from acceptance to refusal. In thinking about vaccine confidence, we've established the importance of building trust in the vaccine, the vaccinator, and the system surrounding vaccine development and rollout. Increasing vaccine uptake includes actually mobilizing individuals and communities to seek out the vaccine, to support others to get vaccinated, and to recommend and promote the vaccine to their friends and their family. At this point in our work to generate demand for COVID-19 vaccines, we're finding that the strategies to reach people and increase vaccine uptake need to be very focused and personalized. This process requires understanding what's happening in communities and within populations that are hesitant. We need to understand who they trust, what their perceptions are, and the specific concerns that they bring to their vaccine decisions. And most importantly, we need to figure out how to address those concerns. So the framework that we use for building vaccine uptake is based on a stepwise approach. First, we want to make sure that the vaccines are accessible, that they're easy to get. Broadly speaking, this is the case mostly in the US now. The next step is for vaccines to be perceived as beneficial. This means that people understand that the risk of getting COVID or the risk of developing side effects from the vaccine are far outweighed by the health benefits of the vaccine. Currently, this is still where a lot of people are getting stuck. Misinformation in the media and on social media about the risks associated with the vaccine or concerns about how bad the side effects might be are real barriers for many people. Obviously, addressing this misinformation and helping people to work through their concerns is very important for building confidence and increasing vaccine uptake. The next step is convenience. This includes reducing out-of-pocket expenses, making the vaccine easy to get. So this is where we develop policies and practices that grant people time off work, for example, for vaccine appointments or to recover from any side effects, or we develop strategies to bring the vaccine to where people are, to where they live, to where they work, learn, pray, etc. The next step is making the vaccines desirable and appealing. Incentives are a strategy that have been pretty widely used, and there are different perspectives on incentives. They may very well be successful in nudging people into acceptance or into demand to get shots in arms. But there's also the potential for incentives to undermine that trust in the vaccine that's so important, or in the vaccinators themselves, or the system, if they feel at all coerced by the incentives. Making the vaccine normative by presenting it as a social default is also important. So what we perceive our peers and our broader community to be doing, in other words, our perceived social norms, can have an important influence on individuals' decisions and behaviors. And the last step is making the vaccine necessary. And we see society grappling with this step today as businesses, organizations, and communities shift towards policies that require proof of vaccination or vaccine mandates. Though hotly debated, positioning vaccines as indispensable for accessing the things we all want to get back to doing arguably results in more people getting vaccinated. Psychological and behavioral research around vaccine uptake is really rich, and we can apply useful behavioral models and theories to shape our COVID-19 vaccine confidence and uptake efforts. A particularly useful framework, and it's illustrated here on the slide, highlights how various individual and environmental factors influence one another to impact vaccine behaviors. The yellow box represents the internal thoughts and feelings held by individuals, so their confidence in the vaccine, their sense of risk perception from the vaccine and from COVID. The green box represents the external or environmental influences coming from society or peer groups. So these include norms and expectations around vaccination, perceptions of and trust in the vaccine providers. And taken together, these shape an individual's motivation, whether they intend to be vaccinated and how willing they might be to recommend vaccination to someone else. Now, before that motivation results in actual vaccination behavior, there are a number of practical issues, what's labeled here in the blue box. And much of this comes down to how easy, practical, and appealing it is to actually go and get the vaccine. And the takeaway here is that there's many factors, individual, community, societal, and policy, that impact someone's decision to get vaccinated. And simply targeting any one of these elements is not enough. We need to create enabling environments and social norms while also addressing individuals' fears and beliefs if we want to influence behavior. So some of these factors are within our control to address and some are not, but we can design better communication and community engagement strategies if we have data on how our communities and community members think and feel, the social processes that affect them, and the practical issues that they'll encounter on their path to vaccination. And we'll talk more about the approaches to collect some of this data later in the presentation. This slide shows data from the Kaiser Family Foundation depicting longitudinal trends in US vaccination intentions from December to June. And what I want to convey in this slide is less about the actual numbers and more about the shrinking movable middle that we discussed earlier. So the movable middle is represented here by the light blue and medium blue portions of the figure. Those who think they'll get vaccinated soon and those who will wait and see. As we discussed previously, we really need to focus in on this population, as well as those represented by the green boxes, those who are fully hesitant. We need to recognize that these are not heterogeneous groups, and we need to understand the factors that stand in the way of changing their vaccine intentions and behaviors. So I'm going to shift now and talk a bit about the work that CDC is doing to increase vaccine confidence and demand. So CDC's vaccine confidence team supports states and jurisdictions in a number of different ways. The team provides direct support through mobilization teams and deployments to jurisdictions and communities. It can also provide remote support through vaccine confidence consults. These are virtual support sessions during which the team will work with the requester to assess and diagnose vaccine confidence challenges and provide mitigation strategies to address those challenges. The team has a number of subject matter experts with experience in a variety of areas, such as addressing misinformation circulating on social media, which is really relevant and important. Moving to the green portion of the figure, there are a number of materials and guidance documents that have been designed to assist partners with vaccine confidence. One of these is vaccine confidence boot camps. These are virtual sessions that are designed to train groups to assess and address COVID-19 vaccine confidence challenges in communities of focus. So these include interactive components to practice starting conversations around vaccination and for generating strategies for participants' own communities, so really tailored to the experiences they're bringing. The team has hosted these kinds of boot camps for faith-based leaders, for staff from the Department of Housing and Urban Development and the Bureau of Prisons. Vaccine communication toolkits that are tailored to specific communities are also available from CDC Vaccine Confidence Team. These include key messages, fact sheets, FAQs, social media content, and more. And the Rapid Community Assessment Guide, or RCA, provides a framework and modifiable tools to quickly gather information and insights to better understand and address community needs around vaccinations. The tools include guides for key informant interviews, listening groups or talking circles, observations, survey questions, and more. And these assessments have been conducted in a number of different areas, which I'll talk more about in just a minute. The orange section of the figure covers the work the team does to generate behavioral insights around vaccine confidence. The team is working on developing behavioral profiles to better understand that movable middle, as well as other primary audiences. The team also publishes a bi-weekly State of Vaccine Confidence Insights report. This is a great resource that highlights major themes influencing COVID-19 vaccine confidence and uptake, categorized by their level of vaccine confidence degree of spread, and how that theme is changing over time. So this report identifies emerging issues of misinformation in places where intervention efforts can positively impact vaccine confidence across the US. It's available on the CDC Vaccine Confidence webpage. Recent issues have focused on perceptions and sentiments around booster doses following the administration's announcement on August 18th about a booster dose program. And an issue was actually just released yesterday as well. We can share that in the chat, highlighting that the Delta variant continues to drive concerns about the effectiveness of current COVID-19 vaccines. The tribal support section has been working really closely with the vaccine confidence team to adapt many of these resources for tribal populations, including the vaccine confidence boot camps, a rapid community assessment guide, and some other toolkits for tribal populations. And the tribal support section can also work directly with tribes to help build vaccine confidence in their communities. So as I mentioned, the Vaccine Task Force has conducted a number of rapid community assessments, or RCAs. As an example, one was recently conducted in 3 counties in Indiana back in May. And the methods included using key informant interviews, listening sessions, observations, and windshield tours, which are essentially driving around the community and observing things like signage, access issues, other community cues and prompts, and messaging around vaccines. Some of the key findings from this assessment were that leadership in all 3 counties were really trusted by the community. There was good vaccine supply and low wastage, and multi-channel communication strategies to improve vaccine confidence were in effect. So those were all great things that were happening. With respect to challenges, the team did observe distrust among some community members, distrust of the government, healthcare professionals, especially among those who had reported a history of feeling dismissed or mistreated by these entities in the past. Specifically, Latinx and an Amish community reported feeling marginalized. There were also language and access barriers for some community members, and misinformation and disinformation were also, not surprisingly, identified as an issue, as they are in many communities. Another assessment finding that was interesting was a low COVID-19 risk perception. At the time of the assessment, this community was really not hit hard by COVID, which is great, but it also meant that a lot of people either didn't feel susceptible or didn't perceive the consequences of COVID to be severe. Hence, they didn't see the need to get vaccinated. Finally, there was a lack of vaccine endorsement by trusted leaders. Unfortunately, some of the healthcare providers and faith leaders in the communities were not willing to endorse the vaccine or to encourage their community members to get vaccinated. Since this RCA in Indiana, the community has been working to help and implement strategies to address the challenges that were identified during the assessment. So as we think about this journey to vaccination, we can call it, it's important to consider the barriers and the enablers that individuals are going to encounter at each step along the way. And while I walk us through some of these steps in the journey, it would be nice if y'all can think a little bit about your own communities or the communities that you work with, and reflect a little bit on those barriers and enablers that you've observed or encountered, either in your own journeys to vaccination or for those that you serve. And feel free to put your thoughts in the chat. In the interest of time, maybe we won't discuss them in the middle of the presentation here, but it would be really nice to hear from others and kind of take note of the diverse experiences. Maybe we can come back to these if we have time in the Q&A. So the first step is related to developing knowledge, awareness, and beliefs around the vaccine. This includes COVID-19 risk perception, both susceptibility and severity, perceptions of vaccine safety and efficacy, and whether vaccines are being recommended by the people that we trust. The second step is understanding intent to receive the vaccine. So this is the step where trust really comes into play. Intent often depends on our trust in the people, again, providing and administering the vaccine, the benefits of the vaccine, and the social norms around vaccination. The third step, preparation, cost, and effort, relates to logistics, essentially. How much of a hassle is it to get vaccinated? How hard is it going to be to make an appointment? How long will it take? How much will it cost me? Will I have to take off work? Do I have to find a babysitter? And so on. But once we get past the hurdle of scheduling the appointment, the next step, point of service, presents additional opportunities for positive or negative experiences when you show up to get your shot. Is it a clean and comfortable location? Is it easy and safe to locate, to park, to navigate? Similarly, the next step relates to the quality of care you receive by those providing the vaccine. Were the procedures and the side effects explained to you? Did you get your questions answered? Did you feel well cared for? And finally, after you get your vaccine, at least for the 2-dose vaccines, how do you feel about doing it all again for your second shot? Do you feel confident in the overall processes and systems of ensuring vaccine safety? Are you willing to advocate for others to get their shots? So that's the journey in a nutshell, and hopefully that stimulated some thoughts about where you see the enablers and the facilitators in your own communities. I'm going to move on now to discuss some strategies for building vaccine confidence and demand. So before getting into the specific strategies, I wanted to address 2 guiding principles for vaccine confidence work. First, the role of trusted messengers in building vaccine confidence and encouraging vaccine uptake cannot be overstated. We need to identify who these trusted messengers are for the different populations that we're working with. They're essential to establishing credibility of information, combating misinformation, and facilitating dialogue and 2-way communication. Second, it's important for us to understand that it takes more than one conversation to change minds and behaviors. At this point in the pandemic, there have been a lot of one-way communication that's been disseminated through public service announcements, through health departments, other kinds of mass communications. Vaccine hesitancy is really rooted in lack of trust at this point. So to best address this lack of trust, we need to be engaging more in 2-way dialogues using the trusted messengers in trusted spaces. People need to feel heard, and they need to be given safe spaces to ask questions. The vaccine confidence boot camps that I mentioned earlier are designed to help participants hone their skills in engaging in these types of discussions with peers and family members and friends. These can be really difficult conversations, as I'm sure some of us have experienced, but a little bit of training and practice can really make a big difference. So there's a number of specific strategies that we can employ to build vaccine confidence. These are things we can do in our everyday, as well as some more involved strategies that we should be supporting in our work and with our communities. And I'll cover each of these in just my last few slides here. So first, make your decision to get vaccinated visible to others and really celebrate it. This speaks to the importance of social norms. It makes clear that most people in the community are getting vaccinated, that they support this decision, and that it's important to your community. And even better if you're a trusted messenger in your community and positioning yourself this way. There's a number of ways to do this, including giving out swag like masks and stickers and things like that. With permission, you could post a photo gallery of individuals celebrating vaccination, put this up in common areas of schools or clinics or places of worship or online as part of a social media campaign. Again, with permission, you can record testimonials around vaccination. Especially powerful can be the stories of those late adopters who are describing their journey to vaccination. Coming back to the trusted messengers, encourage tribal elders, tribal chiefs, and other trusted members of the community to be vaccine champions. Talk to your leaders about vaccine confidence, ask them to lead by example, and document their testimonials through social media, community gatherings, or other outlets. Another strategy is to host talking circles or other spaces where community members can provide input and ask questions. Virtual talking circles, town halls, live Q&A sessions, these are all great ways to offer public health professionals or other trusted messengers the opportunity to engage the public to disseminate vital information. Now, for these discussions, when you're planning, you want to make sure that you have a designated facilitator that's trusted by the participants. You might also want to think about inviting representatives to serve as panelists from healthcare systems, from labor unions, schools, or other community entities, depending again on the issues or concerns that are relevant for your community. And it's important to ensure that all materials that are reviewed or presented are provided in a way that people can access. Finally, you want to share key messages with community members through social media, news media, storytelling, and other channels. Develop messages that are going to resonate in your community based on the information that you've already gathered about their concerns, about their interests, and their information needs. So there's just some examples of key messages here. Being fully vaccinated can help to protect your family, community, and elders who cannot get vaccinated. Getting a COVID-19 vaccine, it's fast, easy, and free. COVID-19 vaccines are effective. They can keep you from getting and spreading the virus that causes COVID-19. And there's some other examples here too. But again, the important point is really tailoring these to your community. So that's all I have. Thank you so much for allowing me to share some of this information with you. I really hope it's been helpful. I think hopefully we have some time, a couple minutes for some Q&A.
I do have a question. The vaccine boot camp, I think, is really good. And USET, we actually wrote this into our 5-year epicenter renewal that just went in on Tuesday. To do something similar. We called it peer counseling in the application, but I mean, it's essentially the same thing. So that is absolutely fantastic. And we had figured we'd have to engage a contractor for that. But the CDC is going to provide that. Now, that said, we serve 33 communities or 33 tribal nations within USET, and then there's 3 more we offer services to, especially during the pandemic. Would it be possible to do, we may have to do a lot of these sessions, to do a train the trainer where you could train USET staff to do the training for the tribal citizens?
Yeah, I think that could absolutely be a great option, kind of a cascade training. So like you said, train the trainer. I think that the boot camps, in terms of like the practice that you get in starting these conversations, and really, I think the beauty of those boot camps is really tailoring and targeting them to the participants and what they need and the kind of conversations that they're going to be having. We can absolutely, I can share our email address in the chat for follow-up, for contact information or links to some of the key resources. And if that can be shared in this group, all the better.
I have a question. I keep reading this percentage, and it seems pretty consistent, that 96% of physicians in America are vaccinated. Is that an accurate figure? Do you know?
I don't know. I can't speak to that particular statistic. I can certainly look into it and see, do you know where kind of citation for that?
I've only seen it
pop up
quoted in newspaper articles, and it's been a consistent figure that I've seen in newspaper articles. But things make it into the news that are completely inaccurate, but then everybody else picks it up and just keeps repeating it. Yeah, I don't know if that's true or not. And you talked about influential community members. I find that when a healthcare authority, such as a nurse, physician, etc., is opposed to vaccine, they seem to get a lot more traction than those of us who, are very pro-vaccine. We recently, though, had a very well-respected ophthalmologist in our community who last week actually died from COVID, and he was unvaccinated and had been fairly outspoken about it, which, I had a lot of respect for him as an ophthalmologist. I was really kind of surprised when he, stepped up into the anti-vaccination sort of group. And, I sort of have a wait and see attitude about how his death from COVID has an effect on the local community in terms of what they think about vaccination. I've had a lot of those difficult conversations, both with family and patients, about the vaccine. And while, it's very interesting to see those polls of vaccine hesitancy and how consistent the I'm never going to get vaccinated number has been month after month after month. It's 13, 14, 15%. And that number hasn't changed. So if we need 90% for herd immunity, we're never going to get there. Hopefully it's a number short of that. But anyway, wonderful presentation. Thank you to both of you for such a great presentation.
Thank
And
you.
I'm gonna stop talking.
Or keep talking and put yourself on mute.
Yeah, that too. I'm just gonna stop talking and put myself on mute.
I do that often. Well, thanks for sharing your perspective. And my colleague Vivian put in, I think maybe the citation for where that's coming from. Vivian, do you have anything you wanted to add to that? Not to put you on the spot, but I will.
Good morning. I don't actually have anything to add, but I had also read and heard the same statistics. So I had looked it up previously. And so I just put the link in there for the AMA survey so that you can read that over on your own. But it does, I think the caveat that I kind of read into it is it's practicing physicians fully vaccinated against COVID. So just wanted to share that link.
Thanks, Vivian.